it did not work, but I hope now it work. I will be showing many of the complex pediatric cases. What we have to do, we have to diagnose, plan, innovate, execute, and follow up these patients. This is one patient where it is a jonular cataract. First I will like to show a simple case. For the beginner, we will always like to stain the anterior capsule for the beginner and make about 5 mm continuous curvilinear capsular axis. And then remove the cortex from the capsular bag after multi-quadrant hydrodissection. Once the cortex is removed, then we fill the capsular bag with viscoelastic and make posterior continuous curvilinear capsular axis, initially with the needle cystitome, and then subsequently we complete it with the utrata forceps. Size of the posterior axis is kept around 3.5 mm. So this is time salon for removal of any vitreous tag, but then all the cases we use hydrophobic acrylic IOL, whether it is a 3-piece IOL or whether it is a single piece. Most of the time we use single piece IOL. It is very easy to pass it into capsular bag. Now I will like to show the complicated cases. They include PHPV, ophthalmos, uveitic patient, coloboma patient, and some of the other complicated cases. Even posterior lenticonus is found to be very you have to diagnose it before surgery. This is one such patient of posterior lenticonus, which we dilate each of the eye of the child and then plan the surgery. This is completion of the rhexis. This is followed by limited hydrodissection. Actually, if you do much more vigorous hydrodissection, it will rupture. So you have to do very limited hydrodissection. I am not putting any pressure on the posterior capsule. It is a pre-existing posterior capsular tear in lenticonus. So here hydrophobic acrylic IOL. This is implanted into capsular bag, and any of the vitreous is removed, and you can more importantly find out the tag, that there may be vitreous tag. So this is the final picture here, and this is after 8 months there is a posterior capsular opacification. This is anterior segment OCT, and this locate the IOL position. This is another child where there is a juvenile idiopathic arthritis and uveitis, and there is a cataract. Pupil is very small, and in such patient we use Malaysian ring. Stretching will lead to more tears, so Malaysian ring is ideal for such cases. This will give adequate dilatation of the pupil, and here rhexis is done, and then removal of the cortex and removal of the lens epithelial cells. You can put either of the IOL, whether single piece or 3-piece. In such patient in chronic uveitis, we like to do peripheral iodectomy, which is not routine in pediatric cataract surgery. This is one child with 4-year-old child with congenital lenticular coloboma with astigmatism. So here issue is the stabilization of the capsular bag. There were posterior synecdoche, so those synecdoche were released, and rhexis is completed. Then actually what we have to do, we have to use hooks. These should be capsulorhexis hooks. There are iris hooks also. Many a time we use that also, but their edges are not smooth, so they may lead to tears of the rhexis margins. Here we are using Sioni ring. This is a single eyelet Sioni ring, but if it is much more subluxation, you have to use 2 eyelet Sioni ring, or you may use 2 Ahmed segment. So we have used Callisto in this child, and implantation of IOL into bag. So we achieved very nice fixation. For closure you can use glue, and this is the final picture before and after the anterior segment OCT. This is a child, small clip, 4-month-old child with the double crystalline lens. We have a completed follow-up of this child now more than 9 years at present. Child is now more than 9 years, and here 2 rhexis were done on each of the lobe of the crystalline lens, and we customized the IOL. IOL was you can see 18mm IOL, which many companies they will fail, particularly those foreign companies, they will fail to. But here we have implanted IOL in the bag, and this child we did occlusion therapy. Child can see through this eye by capturing even the smallest object. Then most important issue is persistent fetal vasculature. This is very, very common. So each child you have to dilate and see, but this was a little unusual because this is a hemorrhagic type of persistent fetal vasculature. You must have cautery with you, and cauterization of the this posterior capsule has to be done so that there is no bleed. And sometime even you have to cauterize the stalk so that there is no bleed once you cut it. And then vitrectomy in the zone of posterior rhexis, and then this is the implantation of IOL into the actually it was captured here because it was placed in the sulcus and captured because posterior capsulotomy was large. This was just to stop any bleeding in the which may not occur in the post-operative period, although we have done nice cauterization. These were some of the other children where we have done PHPV with the IOL implantation. So this is so in conclusion, favorable outcome can be achieved in these complicated cases. We have to plan and meticulously perform the surgery. Thank you very much. So this was just a 10-minute video. I made it because there are so many complicated cases, but I thought that I should show simple case and few of the complicated cases.
Thank you, sir, for excellent surgeries. Now I invite Dr. Sableen to present Dr. Jaspreet's talk. Intraocular lens implantation in children, when and where to place?
Yeah.
As usual, excellent presentation, sir. In cases of PHTV, role of radiologist is immense. So, as they do color Doppler and diagnose vascularity. So, in pre-operative period, it is very helpful whether a stalk is vascular or non-vascular. So, one can take precaution accordingly.
I think that is a futuristic idea because usually these children, they are detected to have this PHPV post-operatively, because this persistent fetal vasculature, it closes almost within a month period. In the first month after birth, almost 97 to 98%. So whatever other cases are there, for curiosity or for that, I think, but intra-uterine we have not done any.
Okay, sir. In last one case, I have operated 1 month back. I have sent that patient for color Doppler, and they have reported that a stalk is non-vascular. And during surgery, it was found that it was just atrophic stalk. The vascularity was not there. So it can be confirmed.
Yeah, definitely. I think that will be helpful. If it is done, that will add another. This will be definitely nice.
Thank you, sir.